Hello everyone and welcome to Advanced Tissue's online webinar series. Today our topic is palliative wound care when healing is not a realistic goal. Each recorded session is eligible for one contact hour, so complete the information at the end of the program to receive your certificate. I'm Carolyn Brown, your presenter today. I've worked in wound care education for more than 25 years in the acute care, long-term care, and hospice setting. I've been an invited speaker at state and national conferences on wound care. However, the most rewarding part of my work is consulting with the clinicians in the field and help them treat their challenging wounds. I'll read the learner objectives just in case some of you are listening away from your screen. After attending this program, the participant will be better able to define palliative care and discuss palliative goals, discuss non-healing wounds, discuss palliative wound care goals, and describe gentle wound treatment interventions. We'll also discuss documentation of palliative care. I'll refer to patients in this program. However, I'm aware that we care for residents in long-term care and now also clients. Let's start with a definition of palliative care. This is specialized medical care for people with serious illness that focuses on reducing the severity of symptoms rather than delaying or reversing the progression of the disease or providing a cure. The goal of palliative care is to improve quality of life both for the patient and the family. Palliative care can be the main emphasis or offered concurrently with all other life-prolonging medical treatments. There are two approaches to palliative care that I will mention here. The familiar and historical model applies curative and life-prolonging interventions until it is realized that these curative measures have been unsuccessful. And at that point, the focus may shift to managing symptoms and palliation. An alternative model provides both curative and palliative care interventions concurrently, and the care plan is modified as changes in the condition indicate. As a patient's illness progresses and death nears, the goals of care, including wound care, may change by shifting from cure to comfort and from prolonging life to preserving dignity. Let's review the fundamental goals of palliative care. First, preventing pain and managing the symptoms of the disease is primary. Also, we need to promote optimal function and quality of life. This will require an individualized care plan to meet each patient and family choices. And also offering support to the patient and family. One of the best ways we can help is to provide pertinent, reliable information so they can make well-informed decisions about care. Other palliative issues that often create a challenge include culture and language. Individual cultures view death and dying in different ways. A sick or dying person's culture is an important factor in whether they will be comforted, isolated, accepted, or rejected by their family system. The patient or family's spiritual perspective is also of consideration. From my experience, another significant issue in palliative care is the clinician's attitude or their belief or perception of end of life. I've worked with many nurses in wound care who weren't comfortable with maintenance or comfort care and insisted that everything should be done for the dying patient, including heroic measures to heal their wound. Clinicians may feel obligated to continue best practice interventions or may be reluctant to withdraw or abandon aggressive treatment. It's always a complex situation when the patient's decisions create a struggle for the clinician and are inconsistent with the way the clinician measures the quality of her work. Palliative care does not mean no care. Palliative care at the end of life focuses on symptom management, which involves active listening, precise assessment, skilled interventions, and constant re-evaluation on the part of the healthcare team. Accurate documentation of goals allows the clinical team to implement the treatment plan consistently. End-of-life preferences are identified by the patient and family based on what they consider most important about care, and then an individualized care plan is developed. Patients and families may need help to identify realistic goals and also be advised when these goals need to be reassessed. Let's go on here to discuss specific palliative wound care interventions. Palliative wound care will focus on minimizing symptoms. The most bothersome symptoms usually include pain, exudate, odor, and infection. Frequently, family members feel extremely uncomfortable with the topic of death and dying and are unable to talk about the end of a loved one's life. This frail palliative wound care healing probability assessment tool is a useful guide in considering the realistic healing potential of the patient's wounds. The more items checked on the probability assessment list, the less likely the wound will achieve a sustained complete closure. I know this may be small on your screen, so just let me know if you would like a copy and I will send it to you. I use this often. I just sit with the patient and family while they check off the statements that apply. Most times, I don't even need to say anything else. I just help them by explaining and describing treatment options and their strategies. Let's talk about the range of appropriate palliative wound care strategies. Clearly, if the patient has no wounds, prevention of skin breakdown will be the focus. If the patient has a wound, we need to evaluate if healing is a realistic expectation and does this wound have the potential to heal. Let's say the patient is fairly mobile and has a good appetite. We may take an aggressive approach and include products such as collagens to jumpstart healing. As the patient's condition declines, a maintenance-only approach may be indicated, including routine dressing changes and a turn schedule. When actively dying, prevention and treatment of a wound may be superseded by comfort measures only. At that time, we can minimize the frequency of dressing changes and repositioning. Eventually, the patient or the family speaking for the patient may indicate their preferences only be observed, such as the dressings are reinforced only as necessary. Studies indicate that approximately 68% of the wounds you will manage in palliative wound care are related to pressure. Today we will discuss a unique pressure ulcer called the Kennedy terminal ulcer, and we'll also review care of skin tears, moisture-related skin damage, fungating malignant tumors, and radiation dermatitis. As you know, a pressure ulcer is injury to the skin and underlying tissue, usually over a bony prominence, as a result of pressure, or pressure in combination with shear. These wounds are usually over a bony prominence, and the treatment plan, of course, will identify risk factors for skin breakdown, maintaining individualized pressure ulcer prevention interventions, and if a wound occurs, maintaining a balanced wound environment. The Kennedy terminal ulcer is an unavoidable pressure ulcer that may develop suddenly in the dying process. The Kennedy terminal ulcer is also known as the 3:30 p.m. ulcer, in that the patient's skin can be intact in the morning, and then at 3:30, when the patient's skin is reassessed by the afternoon shift, this rapidly progressing terminal ulcer is identified. This wound is usually a pear-shaped sacral wound with irregular borders. Treatment for the Kennedy ulcer is the same as for any other pressure ulcer. and little can be done to stop a true Kennedy ulcer, and its rapid decline can be a sign of impending death, usually within 2 weeks. These images shown on the screen are a 2-week progression of this Kennedy ulcer. Skin tears are identified as a traumatic wound, usually occurring on the extremities and resulting in separation of the skin layers. Skin tears are found to be the second most prevalent type of wounds in palliative care. The treatment plan always includes prevention. I'd like to draw your attention to the International Skin Tear Advisory Panel, who has developed a very comprehensive toolkit including a risk assessment prevention care plan and treatment guidelines. Everything you will need regarding skin tears is in this toolkit and is available at this website. Treatment interventions for a skin tear include approximation if there is a flap and covering with a non-adherent product to protect from injury and infection. It is no longer best practice to use steri-strips or transparent film dressings. Non-adhesive products, including hydrogels, foams, and alginates, are suggested. Skin that is continuously wet from contact with wound exudate, urine and stool, and perspiration is at greater risk for skin breakdown and infection, and is referred to as moisture-associated skin damage by the CMS. When urine is present in combination with feces, which contains bacteria and harsh gastrointestinal tract enzymes, the damage can be faster and more severe. In addition to this chemical irritation, the mechanical irritation from cleansing the skin can compound the damage. The treatment plan is to recognize the cause of the moisture, then identify prevention and treatment interventions. I recently cared for a frail bone cancer patient who was continent, but due to severe pain with movement, he was at high risk for functional incontinence and skin breakdown. An indwelling catheter and fecal containment device was initiated. The use of an indwelling catheter to control urinary incontinence, while not a desirable approach in any other population, could be considered appropriate in palliative care. Radiation dermatitis is caused by radiotherapy or radiation therapy and often occurs within the first 4 weeks of treatment. While radiation dermatitis usually resolves, it can have a very major impact on a patient's quality of life. The Oncology Nurses Society classification for skin reaction is a scale from 0 to 6 used for classification of skin reactions related to radiation therapy. Radiation skin damage can be superficial, as pictured here, with a score of 1, identifying the radiation field has faint erythema, or more serious reactions up to a score of 6, which describes ulceration, hemorrhage, and necrosis. The treatment plan includes moisturizing the skin if radiation is causing dryness. A gel or hydrogel may be very soothing. If the area is moist or draining, a non-adherent contact layer and foam are appropriate choices. Use of topical corticosteroids may be recommended to reduce discomfort and itching. The term fungating describes a condition that occurs when malignant cells infiltrate and erode the barrier of the skin. The characteristic malodor is caused by dimethyl trisulfide, which is a product produced from bacterial decomposition. The same is in the early stages of human decomposition. 62% of fungating tumors will develop on the breast, the head, and the neck area. Characteristically, this tumor is fast-growing, produces copious amounts of exudate, has a foul odor, and bleeds easily. Healing these wounds is unlikely. unless there is a good response to radiotherapy, chemotherapy, or the wound can be surgically excised. The treatment plan for malignant tumors includes decreasing odor, containing the exudate, stop the bleeding, and do whatever is possible to maintain a comfort and quality of life. It's important to select dressings that will comfortably absorb heavy amounts of exudate, such as calcium alginates, that can be contoured to cover irregular shaped tumors. Dry dressings should be avoided as they can contribute to bleeding on removal. Wound bleeding is common in malignant tumors, so let's talk a minute about preventing and managing bleeding. Preventing bleeding is particularly crucial in treating malignant tumors. Always attempt to minimize the frequency of dressing changes, and cleansing by irrigation rather than swabbing will reduce the risk of trauma and bleeding. Utilize a non-adherent contact layer, such as Telfa or Adaptic, to prevent the dressing from sticking to the wound and peri-wound. If bleeding should occur, apply a pressure dressing such as a calcium alginate or a super-absorbent dressing. A variety of other strategies to treat hemorrhage may also be included. Applying variations in temperature to promote vasoconstriction, such as an ice bag. Many of you have used silver nitrate sticks. They can be rolled along the edge of the wound to stop bleeding. After the treatment, a moist dressing such as a hydrogel is recommended. Ferric subsulfate solution, also known as Moncel solution, is a styptic or hemostatic agent. A cotton-tipped applicator soaked with this solution is pressed against the open wound and held for a few seconds. This is usually enough time for a seal to take place. Epinephrine 1 to 1,000 solution is another topical vasoconstrictor and can be sprayed onto the wound, followed by application of epinephrine-soaked gauze to the wound base. This is an off-label use. Just remember, off-label. Afrin nasal spray is a vasoconstrictor, available over the counter, and when sprayed directly onto the wound, it helps to control mild to moderate bleeding. Remember, this is also an off-label use. While you're managing an episode of bleeding, try to cover the area with dark-colored towels, such as a blue or green, to limit visual exposure to the blood, and reassure the patient and family that you're doing everything necessary to stop the bleeding. The major and most troublesome wound symptoms include pain, exudate, infection, and odor. Several studies have reported that pain was the most significant consequence of having a wound, and it affected every aspect of the patient's life. Pain is the most common symptom that is often undertreated and the one that dying patients fear the most. Minimize wound pain during dressing changes and repositioning can be best accomplished by coordinating with the patient's regularly scheduled pain medication. Based on your assessment, a topical analgesic such as a 2% lidocaine gel or a topical morphine applied directly to the wound bed may also be indicated. I recently cared for a patient who was terribly apprehensive about the daily dressing change to her right breast tumor. I had an order for 10 milligrams of morphine sulfate in 8 grams of a wound gel, which provided an excellent outcome. I applied the topical morphine an hour before the dressing change, and she was comfortable until the next dressing change the following day. Another effective application is 1 or 2 30-milligram morphine tablets crushed and dissolved in a gel. Patients usually dread the removal of a dressing. Always be prepared with normal saline to moisten a dressing if it should stick to the wound. And also remind yourself to change that treatment order to a non-adherent contact layer. Consider if showering is an option for cleansing the wound. Allow the water to contact the skin above the wound and allow it to run over. The patient is not able to shower, then gently irrigate the wound with warmed normal saline instead of swabbing. This will remove loose debris with minimal wound irritation and discomfort. Avoid unnecessary manipulation of the wound by selecting products that need to be changed less frequently. If the patient is at a stage of preference only, change dressings when they are saturated, leaking, or uncomfortable for the patient. Otherwise, reinforce the original dressing for as long as possible. Next, just a quick word about positioning. Customize the frequency of turning and repositioning for comfort and coordinate full body repositioning with the pain medication schedule. Increasing immobility is expected as the patient becomes more ill, yet it is important to keep the skin intact for as long as possible. Placing the patient on an alternating pressure low air loss mattress to provide redistribution and moisture management will help maintain intact skin. These mattresses reduce the need for frequent turning. However, turning is still required. For those individuals who are actively dying, prevention and treatment of a wound may be superseded by the need to alleviate pain. Many individuals have a position of comfort, and their choice must be respected. I've received a number of questions this month about weeping, so thought I would include a mention of it here. Weeping is caused by elevated leg pressure. The thin walls of small veins and capillaries allow the water portion of the blood to leak out. This fluid fills all the spaces outside the blood vessels and eventually weeps out onto the skin. Exudate is a liquid produced by the body in a response to tissue damage. Here, the treatment plan includes that after pre-medicating, gently remove and examine the soiled dressing. It will give you feedback about the current treatment order. If the exudate was contained and the wound bed remained moist since the last dressing change, then the product is appropriate. Then we'll go on to cleanse and reassess the wound, including your best estimate of the amount of drainage, so you can select the appropriate dressing. The rule of thumb for dressing category selection is, if there is minimal or no drainage, a hydrogel or hydrocolloid will provide a moist wound environment. These dressings have low absorbency and will not dry out the wound. Moderate to heavy drainage is traditionally managed with a foam or a calcium alginate dressing. I would like to suggest another option for your consideration, a dressing category based on hydration response technology. These superabsorbent polymers were developed from diaper technology. They bind fluid and convert it to a gel. The contact surface remains moist, yet the heavy exudate is locked away within the other layers of the dressing. This is just a real quick sample of a product selection guide. Please go to the Advanced Tissue website for a detailed product selection guide that can be laminated and kept in your treatment book for reference. Bacteria thrives on wound exudate and moist necrotic tissue, causing odor and pain. The frail and dying patient often lacks the classic immune response to infection, and bacteria thrives, often producing a resistant biofilm. If the patient's goal is to manage odor, we must minimize infection. Pre-medicate the patient, gently remove and properly dispose of the soiled dressings. Do not leave it in the patient's room even if it is properly bagged. A few weeks ago, I was visiting a home care patient and detected a foul odor just entering the house. After a little investigation, I discovered a week's worth of soiled dressings in the trash at the bedside. After thoroughly cleansing the wound, You will need to reassess the wound for signs of infection such as redness and swelling, or increased pain or heat in the tissue surrounding the wound, or a change in drainage such as purulent or a bloody appearance. Debridement may be indicated. Debridement is the removal of non-viable tissue and may be beneficial in reducing infection and odor. There are various types of debridement, and considering the patient's comfort, autolytic and enzymatic are the most gentle methods in palliative wound care. Consider dressings containing silver for their antimicrobial component. Silver dressings are available in gels, alginates, and foams to meet individual drainage demands. Antiseptic cleaning solutions are antimicrobial substances appropriate in palliative wound care and applied directly to the wound to reduce infection. These solutions are beneficial only if there is no realistic expectation of healing. Povidone iodine is a broad-spectrum antiseptic applied topically in the treatment of infection and wounds. Betadine is a brand of povidone iodine and a universally recognized antiseptic solution. In an open wound, iodine serves the dual purpose of cleansing the wound and fighting the bacteria. Acetic acid and hydrogen peroxide cleanse the wound bed and can reduce odor by removing superficial necrotic debris and decreasing the bacterial count. Sodium hypochlorite, also known as Dakin's solution, is bleach, the same as Clorox bleach. The use of Dakin's solution remains controversial, however. If there is no realistic probability of healing and odor management is the goal, Dakin's is appropriate. Dakin's solution is effective, but note Dakin's produces its own odor and can be very strong and irritating to the respiratory system, especially if the patient is in a room with limited ventilation. The presence of a pervasive odor can lead to embarrassment, depression, and social isolation. The single most important parameter for reducing odor is addressing the level of bacterial contamination. The treatment plan starts with identifying and eliminating the cause of the odor. However, this is often challenging in patients with advanced illness. I recently cared for a woman whose only goal was to eliminate an intense odor so her grandchildren would come and visit. She weighed 290 pounds and had a dehisced abdominal wound. Unprotected bowel was visible, and the source of the odor was complicated. I've included this complex scenario in the workshop section of this program for discussion. Debridement is recommended for the removal of devitalized tissue. Autolytic and enzymatic are the most gentle methods in palliative wound care. Effectively managing incontinence by cleansing the skin after each episode of incontinence and considering urine or fecal diversion, and control infection, which we have reviewed. Odor controlling dressings and products are directed at reducing bacterial levels. Activated charcoal impregnated dressings attract and bind the odor-causing molecules and prevent their escape into the area. Just a reminder, the dressing must be sealed and kept dry to effectively contain the odor. If you're trying to keep the odor controlled, you need to put an occlusive dressing on the wound bed. One of the most effective products to manage odor is topical metronidazole. The brand name is Flagyl. It's available as a gel or a cream and is applied directly to the wound once or twice daily for 5 to 7 days or longer if needed. Studies have shown odor decreased in 2 to 3 days. Metronidazole capsules can be broken or the pill form can be finely crushed and sprinkled directly onto the wound bed. Applying dressings or compresses soaked in a mixture of normal saline and metronidazole have also been effective. Silver antimicrobial dressings are popular for use in countering infection and controlling odor. Honey, cadexamor iodine, and Dakin's soaked dressings will also control odor. Once any of these dressings become oversaturated, their odor control action diminishes. One last non-traditional intervention for controlling odor by debridement is biodebridement or maggot therapy. However, it is not yet achieving acceptance in palliative care. Addressing the underlying cause of the wound odor may be limited in terminal patients with advanced illness, so absorbing odors may also be helpful. Charcoal or kitty litter can be placed under the bed. Coffee grounds or beans may have a pleasant association. External odor absorbers in the room are effective as long as they don't become overwhelming. And after any dressing is applied, baking soda can be sprinkled on the cover dressing. Last week, a family member told me about placing dryer sheets over the vents in the room for a very clean odor. Documentation needs to consistently reflect the care plan throughout the medical record. Notes regarding the education and communication with the patient and family are extremely important. Just a reminder, do not resuscitate, or possibly you have changed your terminology to AND, which stands for allow natural death. These orders are incomplete without clarification of the wound treatment goals. Families of dying patients appreciate an update on the condition of the wound and your assurance that everything is being done to confirm the patient's comfort. Let's take a look at a few wounds and apply your learning about palliative wound treatment. Just to review before we assess the wounds in the workshop section, palliative wound treatment follows the patient's end-of-life goals to control symptoms. The appropriate dressing will balance moisture and contain exudate. You don't want exudate or odor to leak out, or you don't want to allow the wound bed to become dry. The appropriate product will effectively remain in place for several days if possible to minimize the frequency of dressing change for comfort. Treat pain systemically and topically, and consider use of an antimicrobial dressing to control bioburden and odor. The appropriate dressing is easily applied and removed without bleeding or injuring the wound. The use of skin prep to protect the peri-wound area is critical. Alternatives to adhesives include, and there are a few pictured here, the gauze wrap, self-adherent wraps, you may be familiar with Coban, and tubular bandage, also known as dressing holder mesh. Here we have Miss Parker. She has a wound on her left heel covered with necrotic tissue. She has a terminal prognosis of bladder cancer and complains of significant pain with any movement. The wound has no odor or signs or symptoms of infection. So what you might do amongst yourselves right now are to select the goals that we would focus Miss Parker's treatment on, and you may choose the product that you would apply. Okay, Miss Parker has an unstageable pressure ulcer. Unstageable because eschar obscures the wound bed. When you are not able to visualize the depth of tissue destruction, the wound is unstageable. Miss Parker's treatment plan is to gently debride the necrotic tissue to minimize bacterial burden. Autolytic debridement is gentle and uses the body's own enzymes to rehydrate, soften, and finally liquefy the eschar. Autolytic debridement can be accomplished by applying an occlusive dressing, such as a hydrocolloid, and change 2 or 3 times a week. A hydrocolloid is an excellent dressing choice for a wound with minimal drainage. Miss Parker's pain medication is given every 3 hours, so the dressing change is scheduled for 45 minutes after the pain medication is provided. Here are step-by-step directions on how to apply an occlusive dressing to a heel. Prepare the heel with a generous amount of skin prep and allow to dry. Cut the 4x4 hydrocolloid dressing at 3 o'clock and 9 o'clock. Here we are preparing the skin with the skin prep. Apply 1/2 of the dressing to the back of the heel and gently stretch the other half of the dressing to the bottom of the heel and frame with tape and warm the dressing with your hand. That allows the skin prep to bond with the adhesive of the dressing to lengthen wear time. In this treatment order, the dressing was changed 3 times a week. Mrs. Jensen has a malignant fungating tumor with heavy drainage and a very foul odor. As we have said, malignant tumors rarely heal, so the treatment plan is to maintain quality of life through symptom control. As you can see, the location and contour of this tumor certainly adds a challenge in managing the heavy drainage. The clinician who cared for this patient experimented with a variety of products before finding an effective combination. The drainage was originating from under the tumor, so she encircled the tumor with a calcium alginate rope and reinforced with an activated charcoal. Then she gently applied metronidazole gel to the irregular surface and covered with a gauze pad, and then held all the dressings in place with dressing holder mesh. The odor was significantly improved within 5 days. These are some examples of dressing holder mesh. If you can picture, Miss Jensen's dressings were held in place with a larger size mesh that they were able to secure under her chin, open up the area of the face, and hold the rest of the dressings in place with the mesh. Mr. Blake has a heavily draining stage 4 coccyx wound with bone and granulation tissue visible. Moisture damage is noted to the peri-wound area. Clearly, the challenge of caring for this wound will be applying a dressing that will manage heavy drainage and also protect the peri-wound area. This is a very clean sacral wound. However, the current dressing allowed drainage to macerate the peri-wound area. The treatment plan is to manage and contain the drainage and allow the damage to the peri-wound area to resolve if possible. Let's take a look at a technique called bracketing. To bracket a wound, start by selecting the correct size adhesive dressing, and I prefer a hydrocolloid. Fold the hydrocolloid in half and cut it to make a frame, kind of like when we were children and we would cut out snowflakes out of paper. Apply skin prep to the peri-wound area, then apply the hydrocolloid bracket just beyond the damaged peri-wound skin. Fill the wound bed with the appropriate product for heavy drainage. I've used a calcium alginate here. And then you'll cover and secure the wound with a secondary dressing. Here I've used a bordered foam. Miss Taylor has 2 stage 4 pressure ulcers, one on the right hip and the other on the coccyx. Muscle, bone, and tendon are visible, and it has a very foul odor and heavy drainage. Miss Taylor's treatment plan is to control drainage and odor. The customary products for drainage are a calcium alginate and/or a foam. If we add a silver component to treat the cause of odor, we should realize an improvement. To treat Miss Taylor's wounds, we've lined the wound bed with calcium alginate with silver, and then applied an additional layer of foam. It was an effective combination. We changed the dressing every other day. I think we were able to make such a difference in controlling the odor for Miss Taylor because she was able to stand briefly in the shower, allowing us to really cleanse the wound. Here is the technique we used for treating these heavily draining wounds. The tendency is to start with a foam dressing. When drainage is so heavy as with Miss Taylor's wounds, foam is not enough. So an alginate can be placed as the primary dressing. Then apply the foam as a secondary dressing. Always start the dressing change with applying skin prep. Line the wound bed with an alginate, and in this case we selected an alginate with silver, and then cover it with foam. To improve drainage control, we also added additional gauze, or you may add a superabsorbent product. Secure the wound with the dressing of your choice, such as a transparent or a border gauze. I always frame my dressings with tape to extend the wear time. However, wraps and tapes are indicated if you are covering the dressing with a non-bordered dressing. Mrs. Rhodes has multiple dehisced abdominal wounds following various failed surgeries for cancer. She has exposed bowel with foul-smelling necrotic tissue in the superior wound and heavy drainage in the 3 inferior smaller wounds. Mrs. Rhodes is only 50 years old and terminally ill. She has 8 children and 16 grandchildren who are the center of her world. Her only goal is to manage the odor of her wound so she can spend time with her family. Her large superior wound was identified as the source of the malodor related to the necrotic bowel. Surprisingly, this wound was dry. Drainage was not an issue, so we gently filled the wound with metronidazole gel impregnated gauze and constructed a bracket to cover with a large non-adherent layer. The 3 inferior abdominal wounds were draining exudate and urine. This was a perfect opportunity to utilize the hydration response technology I told you about. Sorbian is the name of one of these products. The venous insufficiency ulcer on the left lower leg had minimal drainage and was treated with a gel impregnated gauze. Mrs. Curtis has pressure damage on her right ear caused by the elastic from her oxygen mask and wearing her glasses. The treatment goal for this wound is protection. Let's take a look at a simple technique to cover an awkward area. For pressure injuries on the surface of the ear, prepare the ear with skin prep and then use a 4x4 hydrocolloid dressing. I cut a 1-inch strip of this hydrocolloid for this wound. Fold this 1-inch strip in half lengthwise, then cut a fringe along one edge. The cuts should be approximately 1/4 of an inch apart. Apply the uncut edges of the dressing first, and then use the cut edges to fold around the edge of the ear. A small piece of alginate may be used underneath if the wound has exudate. This concludes our program for today. Please contact me if I can help you in any way with your wound care program. Again, thanks for your support of Advanced Tissue's educational efforts. And for more information about the specific wound products, go to the Advanced Tissue website.